This is the Maryland ACP chapter, Richard B. Williams, medical student, virtual conference for the Mid-Atlantic chapter. So thank you for joining us. I want to thank our sponsors for this morning, the Maryland Armed Forces and the AUA College of Medicine. I want to thank you, all of you that presented this morning. We heard some great clinical vignettes and even great research presentations as well. And I know our judges are off reviewing all of those right now. It's really hard to pick winners from all the great presentations. Thank you to all of our judges for taking time this morning to spend time with you and review your presentations. And of course, as always, thank you to Ted for making this audio-visual feat happen. Really, you've made this year a very memorable year for all of us, so thank you. And of course, as always, we have to thank Mary Ellen, because Mary Ellen, we all do what Mary Ellen tells us, and she keeps us on track. So thanks to Mary Ellen. So with that, I wanted to take a little bit of time this morning to just kind of reflect on this past year. And as I was thinking about what to share with all of you, it kind of struck me that 1 year ago, let me see if I can advance my slides here. Exactly 1 year ago, almost, on February 29th, 2020, we were together in person at Harbor Hospital in a large conference room for this very conference. And I think that was the last time I was personally in a large gathering. And after that, the world just seemed to change. So we find ourselves now, almost a year later, in our virtual conference. And I will say that we have had many, many virtual meetings and conferences for the Maryland chapter throughout this year. We've had presentations, we've had our annual meeting, we've had evening social meetings, we've had committee meetings. So we've really kept all of the great work going throughout this year. So somewhere between February 27th last year and today, this little virus kind of made its way into the world. So the virus, it's not the first time the world has seen a virus, but certainly is probably the first time we've seen something of this magnitude spread so quickly. So if you all remember, the first case was detected early last year, 2020. Then the first case was then reported to the WHO, and you can see the timeline here. Then the first identification of this new novel COVID-19 or COVID-19 virus was detected, and it was actually named, the reason it's called COVID-19 is because it was discovered in 2019. And then we see the first fatality was reported. Then we start to see borders being closed across the world. We see countries declaring health emergencies. We see the suspension of movement across the world through flights and other modalities. We then see the WHO says this is a high risk organism. Still at that point had not been declared pandemic. We then see more flights being suspended into China, which is where it's felt the virus originated. And you can see there that continuously movement is being restricted across the world. And you can continue to see that as we kind of progress into that month of into 2020, really becomes a pandemic. Not the first pandemic. So you can see here we've had other pandemics. We've had polio, smallpox, Legionellas, Ebola, HIV, E. coli, anthrax, SARS, Ebola came back, HIV, hepatitis, and then Zika. So, and then we've had the MERS that came after that. So clearly not the first pandemic. The difference with this pandemic, probably more than any other, was the fact that globalizations occurred. So these viruses have no boundaries. They don't recognize geography. They really don't care if it's a plane, ship, or automobile. They find ways to travel. And you can see that viruses can start in the remotest corner of a continent and very quickly make their way across the globe. And it's interesting to me when I saw this slide that it takes approximately 36 hours with all of our modern transportation for a virus to reach a remote corner into a much more dense population. So this I thought was a very nice slide as well. And I thought we'd just spend a minute or so walking through this, because I think this kind of hits the economic impact as this virus made its way across the US. So back you can see in January of 2020, you can see that first case report. And then you can see kind of towards the end of January, it made its way into the US. The WHO at the end of January said it's a health emergency. Then President Trump at that time declared a national health emergency and banned travel to China. We all remember the story of the Diamond Princess ship that was quarantined, that was circulating for many, many weeks, just trying to find a home, and there was no port that would allow them to dock. You can see at that time the death toll in China continues to rise. We all remember that Italy was really beginning to feel the brunt of this virus. And if you look at that blue line, you can see what's happening to the economy in the US at the same time, in addition to the movement of this virus. Italy then shuts down, and you can see a lot of restrictions there. We see the first death towards end of February, right around this time a year ago. We start to see federal spending being reduced. We start to see more national emergencies in the US, and we continue to see the economy just kind of plummet over the next few weeks. And you can see then the economic stimulus came into play right in the middle or towards the end of March. And I think this is really important, because a lot of what we're seeing now is a consequence of some of the economic loss over the past year. So what's happening on the operational side? So the COVID-19's response we'll start from a very high level, from a global perspective, then a US perspective, and then a hospital perspective. Really, the overall objectives were that we had to decrease morbidity and mortality from this outbreak. And while doing that, we also had to preserve our social functions, minimize social disruption, and make sure that our individuals that, who did not have COVID, was still able to sustain some degree of normalcy. And we know that, for many months that was very, very hard. So whenever you have a kind of a response that you have to formulate, you need to understand a few things. One is, what is our problem? How do we keep our eyes on the number of cases? How do we know the cases are moving around? How do we make sure when you have an infection, what are those kind of exposure mitigation things that we need to be looking at? What is the guidance we give to our communities, our populations? What is that public information that needs to be available, and what is it we don't want to share because we're not quite sure what that means to the general population? How do we make sure hospitals are supported when we see such a huge influx of patients in our hospital environments? And then how do we manage the death and the mortalities? And I think we'll see when you talk about hospital surge, we saw very early on China was actually putting hospitals up very quickly that could hold 3,000 to 4,000 people. So really, how did they pivot that very quickly? So when we look back at this past year, we all remember that how did we diagnose COVID? What were the testing abilities that we had? We know that it took quite some time in the US to get testing, and then to get testing widely available to people. And that was a significant challenge for us in the US. And then it took us some time to figure out, well, who needs to stay at home? When do they need to stay at home? And essentially what we saw was the world kind of locked down to say everybody needs to stay at home right now so we can mitigate the movement of this virus. For those of us that did have to go out, what was the right PPE, protective equipment? Was it a mask? Was it an N95? Was it a PAPR? Was it eyewear? Was it a gown? Was it 2 pairs of gloves? And all of that was just really evolving, because remember, we'd never seen a virus just like this, so we really didn't know what the best practices were in the beginning. How do we protect our healthcare workers? And then how do we protect our patients? Do we have our patients wear masks when they're in the bed? If we had visitors coming into hospitals, how would we ask them to wear PPE? And I think a lot of you remember that you were not able to do clinical rotations in the hospital. We also essentially had no visitors in the hospital for many, many months either. So it was just the healthcare provider and the patient in the hospital. Then how do we report? So how do we even know what the magnitude of this virus is? And we had to set up very quickly reporting mechanisms. So every time for a hospital, if you had a positive COVID test, we had to report that to the state. The state had to then report that to CDC, and the CDC then reports that to WHO. How do we manage our information? And what that means is, how do we build our electronic medical records, our databases, so we can capture all this information, not just from a surveillance perspective, but also clinically, how are we managing these patients? Contact tracing was a big challenge in the beginning because if we had one positive patient, we all remember that one positive individual, and it didn't have to be a patient, it could have been an asymptomatic carrier, could easily transmit to many, many other people. So how did we kind of take that one person and trace it back? And we know often that one asymptomatic carrier could have potentially exposed dozens, if not more, hundreds of other people. And we saw the world coming up with apps. There were some places in the world that you had to download an app in some countries, and the state or the health authorities were able to track your movement to be able to identify others that may have been exposed, and that was contact tracing. Hospital operations, so really critical. Whilst we had many, many COVID positive patients, we also had patients that did not have COVID. So the myocardial infarctions, the broken bones, those patients were still coming in, and we had to really understand. We had to build new units across all of the hospitals across the world. Where do we put those patients? Very quickly, we had to shut down our outpatient clinics. And what we will see coming out of this past year is really a very, this pandemic has been a catalyst for telehealth. And I'm pretty sure we're going to see telehealth becoming a mainstay of our treatment moving forward. Laboratories. So very quickly, very early on, we had to understand, when we have all these COVID tests, how quickly can we turn them around? Because we need to make clinical decision plans based on if a patient is positive or not. And so it was really, how do we coordinate all of our laboratories? Then we had all this waste. We had all this PPE. What were we doing with it? What were the special kind of mitigations that we had to put in place when we had to pick up all that PPE? All the linens and all the other stuff that comes along with environmental waste, and where did we put that? And then how do we move patients? We didn't quite know how to move patients. Did we mask them? Did we not mask them? Did we put them in some kind of plastic cocoon? And these are all things that the past year has really globally been almost a learning what to do as we were flying the plane. And here's why it was so difficult. And that testing delay was really, really challenging, because we all know the term person under investigation, or PUI. And when you look at these kind of 4 disease states, the COVID-19, just a common cold, the flu analogies, you can see that there's a lot of overlap in these symptoms. So any patient that presented with any of these symptoms, fever, cough, sore throat, shortness of breath, fatigue, loss of smell or taste, aches and pains, headaches, runny nose, diarrhea, sneezing, or vomiting, these are not specific symptoms at all. So, and you can see as we kind of look across those 4 disease states, there's a lot of commonalities and there's a lot of overlap. So any patient that came in with any one of these, really, we were testing all of these patients early on. And remember, we didn't have enough tests. We would put these patients under a PUI banner or label. We would have to wait for these tests to come back. And initially, it was taking us more than 24 hours. And in the hospital, we had to have these patients, we had to find a space for these patients in the hospital. So very quickly, you can begin to see how our hospitals were just filling up. And then initially the sensitivity of some of these tests was not great. So even if you came back negative, but you still had a high clinical suspicion of maybe having COVID-19, we would get a second test. And that would further prolong the plan of care for the patients. So you can see how complex this was. It was a really complex time. And again, everybody was learning as we went along. And then what did we learn clinically? So clinically, initially, hydroxychloroquine. That was the first medication that we were using, and we were using a lot of it. And then very quickly, the study said, well, really, it's not the right drug. It's not doing what we thought it would do, and very quickly it fell out of favor. Then steroids. There was a role for steroids, and there continues to be a role for steroids. The data is coming out. It's much more robust about how much steroids and when. And then remdesivir came about, and remdesivir, the studies were very promising early on. We're continuing to look at the data that's coming out, and we're continuing to learn as we get more and more data. And then we had monoclonal antibodies that came around, and we know that for mild to moderate disease in high-risk patients, this can help lower viral loads, and this can then further lower the risk of hospitalizations. And then we realized that convalescent plasma, which is not new or unique to COVID-19, really there is a role for convalescent plasma in people who have convalescent plasma being plasma from people who've recovered from COVID-19 that then can be used in patients that have COVID-19. And we're seeing more and more data coming out around the use of convalescent plasma. Then we'll move to vaccinations. So vaccinations. So in the beginning, we all heard that it's going to, we all know that vaccinations take years and years to actually reach the patient because they have to go through so many trials for safety and efficacy. So very early on, there were a couple of, we knew the trials were very quick, fast, and furious. And actually, University of Maryland has been leading some of these trials. And the first vaccine that kind of came aboard was the Pfizer vaccine. The Pfizer vaccine, it's 2 doses, 21 days apart. One of the challenges, it's very efficacious, it's about 95% efficacious. One of the challenges is that due to the chemistry of this vaccine, it needs to be stored at minus 70 degrees. That's really, really cold. And that's like a special freezer. So any place that was going to be storing the vaccine, we had to specially order these freezers. And then they're expensive. They have to be maintained. So not everybody can order one. So typically one of these freezers will go to one central place. The vaccine gets delivered there, and then it gets shipped out to other places that can administer the vaccine. Typically, the Pfizer vaccine is studied only in 16 years and above, so not in pediatric patients. It requires 2 doses. And the other thing to note about the Pfizer vaccine, you're probably hearing about right now, that now the question is, well, do we really need 2 doses? So again, we're learning as we go along. The second vaccine that came on board was Moderna. This is, again, a 2-dose vaccination, 28 days apart. It does not need to be stored at minus 70, but it does need to be stored at minus 20, which is a little bit better because that's a freezer that most places that store vaccine and medications have ability to or access to. And as of yesterday, Johnson & Johnson or J&J has been approved as the 3rd vaccine to come on the market in the United States. The reason I bring up these 3 vaccines, I think it's really important because couple of things to note is that one is we're still looking at the pediatric patients. The Johnson & Johnson, I forgot to mention, that's a one-time dose, so only one time. So you begin to think about the challenges with freezers when you think about the underdeveloped countries where they're not able to have minus 70 degrees because minus 70 degree freezers because that's logistically very hard in the supply chain. So this is exciting news. The question now is the Johnson & Johnson vaccine, which patient population will benefit from this one dose administration? I pulled this data. This is Maryland. So I think you look at Maryland hospital vaccine. This is how many people in Maryland have received a first dose. You can see that those are the numbers right there. The gray is how much we have left. That's how much we still have on hand to administer. And the blue is how much we've administered so far. This is the combination of both first and second doses. Again, the gray is how much we have left. And the gray is more because we still have those second doses for those patients that will be getting them soon. A couple of numbers in the US, we have vaccinated 70 million. We've administered 70 million doses, which is 14.2% of our population. We're doing about 1.5 million doses a day. And if everyone remembers that we need to reach to get herd immunity really north of 75 to 80% globally to get herd immunity. Some of the states that are doing this pretty well, Massachusetts, Connecticut, West Virginia, the Dakotas and Alaska are really kind of ahead of many, many other states. And across the world, we've administered 172 million doses. Israel has immunized more than 50% of their population. So this, we reflected on where we were in 2020 for this meeting. 2021, we're virtual. So will we be together in 2022? Well, I don't know the answer to that. I wish I had a crystal ball. My hope is absolutely yes. But in the meantime, we still have to maintain social distancing. We still have to maintain that 6 feet because not everybody's vaccinated yet. And there's still hesitancy around vaccination. So that will be an ongoing effort globally. Do we still have to wear masks? Yes, we do still have to wear masks. And here is when and how we have to wear masks. And we need to continue to remind people that even if you have received your full vaccination, you still need to wear a mask because not everybody is vaccinated. And we still don't have data to say if you've been vaccinated, can you still be contagious to other people if you do as a shedder. People trying to get people back in school and colleges. So again, how do we make sure those are as safe environments as they can be? And then we have this coronavirus variant that's coming up, and we're hearing of the variants coming from South Africa, from the UK, and many other places. And how is that going to impact? Do we know that the vaccine will cover all of these variants? So these are some of the answers, or some of the questions that still remain unanswered. And I think we'll find out throughout the rest of the year what this means for the coronavirus and the pandemic moving forward. So again, I wish I had a crystal ball. I wish I could promise that we'll all be in person next year. I hope that we will be, but really wanted to share where we were last year and where we are this year. And just want to see if, I'm not sure if we have time for questions, Ted. I know we're a little bit over time, or if anybody has any questions.
You've got time for a couple of questions.
Okay, great. Does anyone have any questions for me? Questions, thoughts, comments? I will say, just go ahead.
Oh,
go ahead, Mary.
Hi, Dr. Galati. This is Mary. I'm a student at University of Maryland. A comment or a thought, I guess, is like, I feel like as a third-year medical student, I've been in the hospital, and this is the normal hospital that I walk myself into. Where there aren't family by bedside, where people are zooming in for rounds and things like that. So it's, when you put it into that, this is just a year ago that all of this kind of happened. It's crazy to think that this is what our new normal is. And I didn't even really have a chance to experience what the old way of in the hospital was, but it's crazy that it was only just a year ago. It feels like much longer.
It does feel much longer. And I will share with you that we have residents that joined, brand new residents, interns that joined last June, and they still not been able to be in the same room with their class. And a lot of them don't know what each other looks like because they've only seen each other in masks. So I think, this has certainly been a year to remember. And I will say, just to your point on visitors, I remember early on, in March, where the hospital was was silent. And if you think about the hospital, is always busy with people moving around. It was absolutely silent because we had no visitors. And I would say personally, for me, one of the hardest things for this year has been not being able to have visitors at the bedside, because patients have just been have suffered and died alone, and that just has been, I think, as a healthcare provider, and I can speak, and I know many of my colleagues, that has just been has really been hard.